to get traditional investors over that hump of this market is too risky to invest in. So what I'm going to walk you through is a series of slides on, how people typically view blended financing and where we are now. Even now, as was mentioned by Dr. Solomon, I also co-chair the Women's Health and Empowerment Network. It's a network of women philanthropists and investors. And a little bit of what it's designed to do is provide that catalytic capital and those incentives and programmatic models so that we can move forward in blended financing transactions. So, what is this concept that 12 years ago was called innovative financing, has been called many different things. It's a combination of both how we mobilize traditional commercial capital and then also how we mobilize commercial catalytic capital. And this is sometimes what's called blended financing transactions. The blended financing transaction usually involves public and private capital, including from the development finance, which development finance terminologies I was asked to define for this meeting, includes governments, donors, and development banks. Commercial finance usually includes institutional investors, net worth, family offices, companies. And the financing structures of how we use this, will get creative along the way. One of the things that I find very interesting as my team was doing some research over the past few months and a lot of the blended financing transactions that we've done is that sub-Saharan Africa continues to dominate global blended financing transactions. That activity has outpaced all other regions, which is, I think, prime for this conversation. When we look at the other markets in Latin America, Southeast Asia, and East Asia, we see that Sub-Saharan Africa is really leading. And so what we need to understand is, what is that magic sauce that's making some of these transactions really scale? And then some of the transactions sometimes stagnate and don't move as quickly. And so while, I was also asked to address some of the myths, it's not a silver bullet. It's just not another name for grants. And it's not meant to be a permanent solution, but it's meant to provide that catalytic capital that actually gets investors to create larger financing vehicles like the one you're going to hear from the CIO of Africa Invest into the market. One of the things that we've seen as we've been designing these blended financing transactions at the Center for Global Health and Development is that we see that bridge financing, or what you're calling catalytic capital in some of these transactions, sometimes it could be as little as 1 million. In the case of a fund that we structured for Girls Education Fund for Africa, we saw that a 10 million catalytic capital created the incentive for another investment firm to join. And that incentive created for another private company to join, and then a private foundation. So the catalytic capital that started as 10 million was aggregated through different types of institutional capital, which created a 40 million investment of catalyzing. At the end of the day, because there was 40 million of almost first loss capital, it created an 8x in the available resources. So what started as a grant, and it was a grant actually from an institution you all well know but no longer exists, which was USAID, was able to finally launch into a $320 million vehicle. And so what we see in blended financing transactions is sometimes a little capital can go a long way, but you also need the political will. And sometimes the political will doesn't come from the health sector. It comes from sectors like energy, also tech. And right now in Indonesia, I was asked to speak to another example, a real life example of blended financing. We're seeing that a combination of both energy and access to economic empowerment is providing capital in health. And Indonesia has now secured a loan for over $4 billion. And some of the blended transactions along the way are supporting that loan, not necessarily directly in the areas of health, but have started in other areas such as energy and tech. So sometimes we have to use other sectors to bring us along. I was also asked speak specifically on women and children's health and how we can, use blended financing in a lot of these transactions to empower women. What we see in this is that the sustainability of women and children's health really depends on different types of capital. I mentioned at a high level concessional capital, which means capital not at market returns, and also traditional capital that investors are seeking. And so what we see here is that along these different types of capital, we can empower women both from development financing, funding, concessionality, philanthropy. And we've seen in many philanthropic transactions that it ensures that women have access to income. We've seen some of these in different paying models for paying healthcare workers. But one of the things that's lacking in some of those small private sector models is that they need to be scaled. And so that's where we need to form these financing vehicles, such as the one that Africa Invests has formulated through the Transform Health Fund, to really take initiatives, empower women, address their health, address infrastructure needs, and scale it to another level. I'm not really going to go into the different levels of concessional capital here because once you hear from the CIO, we can dive into that deeper. But one of the things that I'd like to take you through is what would a blended financing transaction look like? A little bit is taking some grant financing, limited resources that are available, adding that to concessional capital investments, and creating a reinvestment vehicle. We've seen that happen through a lot of the different models that Convergence, which is a Canadian private sector blended financing modeling platform, has created. And so when you take a little bit of that TA and aggregate it to form blended financing transactions, you can create different facilities that provide long-term scalable financing in areas such as health and can provide guarantees. Guarantees that we are seeing now as the new blended financing solution, which, as I mentioned earlier, used to be innovative financing. But now with the blended financing transactions, we're really looking to innovate and leveraging the current infrastructure on the ground so it could be scaled. I'm going to stop right here. But in the different areas that you work in and in your different countries, I would suggest that you do a blended financing roadmap. Really identify, your country archetype, what type of financing solution is best suited for you as you're defining the health solution, and prioritize the financing challenges that you want to address so that you can evaluate with maybe some of the experts around the table here that you'll hear from, how to create blended financing solutions and instruments that can really take some of the challenges that you want to see addressed to scale. So I'm going to stop here. I gave a very high level overview, but I really want to turn it over back to our moderator and then to our fireside chat with the CIO at Africa Invest so we can get very practical.
Thank you so much, Joanne. I think just to give you a highlights of a few points that help guide the discussion forward. I think Joanne has emphasized that blended financing uses conventional or catalytic capital to crowd in private investment. It's not the same with public-private partnership, which is predominantly contractual agreement, and its focus is to enhance the efficiency of a private sector. Another important thing here is blended financing combines both public and private and philanthropic resources. And most importantly, for it to take off, it needs a political willingness. So these are one of the things that we probably need to consider when we think of, introducing blended financing into our health system, especially in enhancing women, children, and adolescent health. So having said that, we can now move into a focused conversation on a practical blended financing model with a perspective from Africa Invest and the Genesis, who operate in energy sector. Joanne, who will moderate the fireside discussion. Over to you, Joanne, now.
Thank you so much. So as we discussed, there is a large gap in financing. Blended financing transactions have grown in sub-Saharan Africa, and we want to know what, creates that magic to make those blended financing that is, we're trying to demystify scale. So I'd like to turn it over to a colleague, and we've known Africa Invest for quite a long time, as one of the largest private equity firms in the African continent and one of the oldest private equity firms. So if anybody knows the magic formula, it would be our colleagues from Africa Invest. So I'd like to turn it over to the CIO and ask you, start with a question in terms of, the Transform Health Fund. I know it from very well from my early days in some of that blended financing transaction, and how you took $1 million and made it over $100 million. So if you could take us through the journey at the beginning and see, what distinguishes bankable blended financing solutions from other well-intentioned public-private partnerships. Over to you.
Thank you, Joanne, and thank you, Doctor, for the opportunity to speak today. So it was a long journey, but it was worth it. Definitely, through our 30-year experience in the continent, we've seen a large gap in financing, especially in the healthcare space. We started initially by launching a private credit vehicle that financed SMEs in Africa, but we quickly noticed that over actually a third of our portfolio was related to health because of the substantial gap in the healthcare space. So we partnered with the Health Finance Coalition to come up with a new structure that addresses this gap and that mobilizes resources from different types of investors to bridge this gap. We've seen inconsistent supply of financing in the continent. Some well-intended actually donors come and support initiatives, but it's not sustainable. I mean, they're there, they work for 1, 2, 3, 4, 5 years, and then they disappear. And so we thought that let's build sustainable models that address the gap in the continent. There were two approaches of doing this. Either we go by going deal by deal. So we identify opportunities that we can, in the healthcare space, that we can make sustainable through blended capital by attracting catalytic investors and commercial investors, or we go the wholesale approach. Let's set up a blended finance vehicle that will address this gap. And that's where we came up with this Transform Health Fund initiative, which is a blended finance fund that actually combines catalytic investors that are there actually to mobilize financing from the private sector and entice actually private sector investors to come into the healthcare space in Africa, especially the high impact healthcare space in Africa, which is viewed as very high risk, and the commercial investors that are interested in actually being part of delivering impact in the healthcare space in Africa, but also delivering a risk-adjusted return. This combines private investors, development finance institutions, and the likes that came into our commercial tranche. And the catalytic tranche, these were primarily foundations and family offices. So I'll leave it at this for now, and happy to share some slides to illustrate this. Thank you.
Yes, that would be great. If you could walk us through some of that. I think one of the practicalities, here in the audience is they're trying to learn, yes, we're talking about large funds, but if we're talking about a specific deal structure, I know you've done a lot in the areas of nutrition. You worked hand in hand with some of the governments, as you walk us through some of what the mechanisms are for Transform Health Fund in that blended financing transaction, how can, those practical experiences around nutrition, how can people replicate that? Oh, you're on mute.
Okay, yeah, definitely. So, as mentioned earlier, uh, we were able through the Transform Health Fund to mobilize $110 million, and as you said, Joanne, initially we started with $1 million grant from USAID, and then we attracted other catalytic investors. And then the catalytic investors, which represented 35% of the fund, helped us mobilize commercial capital to bring the total size of the fund to $110 million. So that's the multiplier effect that we managed to deliver through this fund. But talking about nutrition per se, um, um, so we financed actually a company in Kenya, Insta Products, that actually sells and develops food supplements for malnourished children in Africa. And the attractiveness of this opportunity to us was this is one of the few local players in Africa, because the rest has been historically imported from outside of Africa. Its products are recognized in terms of quality, but more importantly, it's certified by the biggest donors, such as UNICEF and the World Food Organization. And this institution actually managed to deliver a quality product at a reasonable price, produced locally. And our financing is going to finance further vertical integration by providing for local supplies of in this case, groundnuts, which are the key ingredient to many of these food supplements. And so we financed the construction of a processing plant to be able to source groundnuts locally in East Africa. And stop importing from Asia and other parts of the world the raw materials to achieve local supply. I mean, basically to reduce reliance on global supplies and have local supplies deliver a local product that is distributed in Africa. What is important here is that the target audience, obviously, for this product is malnourished children. And so the impact thesis of this investment is tremendous. But on top of that, this factory, I mean, if you come to visit it in Kenya, is not only state of the art, but uses the best energy preservation systems that exist in the market. So it uses solar panel, it uses energy efficient cooling systems in the processing. And this factory has reached actually 1 million children in 2023 and expanding its reach even further. Today, following the success of this investment, we're looking at replicating this into Nigeria, and we are looking at financing a similar plant in Nigeria so that we have one in East Africa and one in West Africa. So one very important thesis that we're trying to deliver through this fund is back models that are replicable and that will contribute to enhancing quality of life and enhancing the dailies in Africa, and especially targeting vulnerable children and women.
Thank you so much. And as Africa Invest, having raised over $2.3 billion, since you first started, it's, your expertise in some of this blended financing transactions that we're looking to. So if, I know you have some slides to share, provide some of the modeling overviews for our audience.
Of course. Yeah. So actually what I wanted to show here is the fact that Through this blended finance structure, we brought in catalytic capital from, as I said, foundations. I mean, one of them was actually a family office out of the US that was interested in delivering impact in the healthcare space in Africa. Obviously, we had USAID. We had also FSDA as an investor in this catalytic tranche. And since the development of this fund, we had engaged with global corporates that are involved in the healthcare space, namely Philips and Merck. So Philips, actually, we convinced Philips to split their commitment, $5 million to the catalytic tranche and $5 million to the commercial tranche. We also convinced Merck to join us into this venture. Merck came only into the commercial tranche with $5 million as a sign of basically commitment to the impact thesis of this fund in Africa. On the commercial, for the commercial pool, we managed to attract a few development finance institutions such as IFC and Proparco and Swedfund. The thesis of this fund is to bring together different type of investors that are interested in one mission, which is delivering impact in the healthcare space in Africa, basically addressing the strategy needs of each one of them. So commercial investors are looking for a reasonable risk-adjusted return. Catalytic investors are looking to actually preserve their capital, and they're looking to play a catalytic role and attract commercial capital and de-risk commercial capital. And it's important to combine all of this with technical assistance, because there is a lot of work that goes into preparing these transactions that we finance through this fund, through technical assistance, through what we put in place together with the Health Finance Coalition, a facility called the Deal Construction Facility, which prepares transactions that are not bankable today to become bankable and help them enhance their business model and fine-tune their business model. So that's what we managed to bring together in this case, in the case of the Transform Health Fund. This is patient capital because this is a 12-year fund with 2-year extensions, and we're actually going with 7 to 8 year tenor, and with the capacity to recycle the cash of the fund, which would allow us to deploy over 150% of the committed capital by our LPs. So, I mean, quite a very impactful and very actually highly structured fund that allows us to bring different breeds of investors to deliver one mission.
And I think you mentioned something so important, which is the technical assistance facility.
Yes.
When we at the Women's Health and Empowerment Network just finalized the 50 million technical assistance facility for non-communicable diseases that will include concessional capital and TA, the hardest thing to really get was that, technical assistance will, right? And what we've talked about is that a little money can go a long way, right?
Exactly.
And so I think the future of how we do health and development will really be around those technical assistance, not a traditional grant facility where we're providing grants to healthcare workers, but where we're providing $1 million of a little bit of catalytic capital to seed some funds like the ones you created for Transform Health Fund or others for different countries. So really, if you can take us a little bit through that, Transform Health Fund, if there's been any early successes that you've seen, and what advice you would give to others who are trying to create these vehicles.
Sure. I mean, early successes, we can, knock on wood, today we have 0 NPLs. So we have built a portfolio of high impactful ventures. I'm not saying that this has been an easy journey, to the contrary. But we have worked together with our local partners and into helping build sustainable models. I mean, the other investment that we've made is the Africa Healthcare Network that is present in Kenya, Rwanda, and Tanzania, which runs a very successful PPP model by leveraging existing infrastructure in public hospitals to run professionally run dialysis centers at a very efficient and very reasonably priced service delivery. So in this case, the public hospital puts the infrastructure at the disposal of the company. The company upgrades and makes all the fittings, brings the equipment, and runs these facilities. And it's a win-win partnership. So the government, the host government, for example, puts to good use idle infrastructure, while the private sector, in this case, this company, efficiently managed to source quality products at a very competitive price, because this dialysis centers use a lot of consumables, so there is a lot of importation of consumables and cleansing products that are needed for this service. So here we are part of the governance in most of these investments, which distinguishes us from the classic lender. We're not a bank. We're a value-adding investor that comes in with technical assistance initially to try to fine-tune the model. We ask for an observer seat, so we sit on the board of these companies as an advisor, but not as a decision maker. And we try to create synergies between the different companies in our portfolio. Here, if I may say that, I think we managed to address multiple gaps, but there is one gap that is missing, is how to de-risk the public health insurance schemes, because we've witnessed in multiple parts of the continent delays in payment by these public healthcare schemes. And here, the next step, I think, is for us to find guarantee mechanisms to de-risk these, the delays in payment by these healthcare schemes. That would be terrific. We, as African Invest, have had a discussion with MIGA to try to put such a mechanism in place. However, I think we know that MIGA has done very large projects, but when you come to them with a small project of $4 million or $3 million, it's too small for them, so it's very difficult to get their attention. So it would be great to have a mechanism to distribute the guarantee of such institutions such as MIGA to a lower scale, to allow smaller models to benefit from such a guarantee, to make sure that they're paid in time. All they care about, these companies, is to be paid in time so they can manage their working capital, so they can be able to be competitive, so they don't pay huge late fees to banks locally, so they have cash to order supplies, so they can deliver a quality service. So it's very important that they're paid in time to be able to deliver a quality service, and such guarantees would play a great role. I mean, we've seen this work very well in the energy sector, and we hope that we will be able to replicate it successfully in the healthcare space.
Thank you so much. And I think that's where, guarantee facilities are something that are needed for foreign exchange rates. I remember during COVID when we were negotiating a lot of the blended financing transactions for different governments, the foreign exchange rate was so high that a lot of the different development finance banks were trying to give out financing to different countries to address issues of COVID vaccination. But nobody wanted to take the financing because of the foreign transactions. So I think your point on guarantees, we need to find that guarantee facility. I think we have some capital there for guarantee facilities through the Women's Health and Empowerment Network. So I think I'd like to turn it over back to our moderator, Dr. Solomon, and I really thank you. All the great work that you're doing in the continent, and I'm sure we're going to be able to tap on you. Before I turn it over to Dr. Solomon, I don't know if you had any, call to action for this group or next steps. As again, you are the largest and also the oldest private equity firm in the continent.
Sorry, this question is addressed to me, or I'm
Yes,
just
to you.
yes, okay.
Maybe this is a call to action before we turn it back over to
Yeah.
Dr.
Look, I mean, I think that there is a lot to do, and we're really keen on being part of the discussion and to see how we can bring our efforts together and our ideas together for the good of our continent. We're born in this continent. I mean, we cherish this continent, and we need to be able to address the gaps that exist and build solutions, sustainable solutions for the good of all our communities. And I mean, I mentioned one example, the guarantee mechanism, but there are other things that we can discuss. The key here is to build sustainable models that are sustainable in the long run, and deliver quality healthcare services at a very low price point. I mean, one anecdote is that when you look at what India has been able to achieve in terms of cost of delivering healthcare services at a very low price point, I think that should be our objective, is to lower the cost of delivering quality services, and we should work together in achieving that. Thank you.
Thank you. And hopefully we will over the next series of sessions. Back over to you, Dr. Solomon.
Thank you, Joanne. Thank you, Skyler. I think, thank you, Skyler, for the promise as well. This conversation is about women, children, and adolescent health. Protein, energy, malnutrition is an important cause of child mortality and morbidity in sub-Saharan Africa. And then you bring up this important point about the production of plant peanuts. If you look at Ethiopia, we import them from India. We cannot maintain the standards here. So, these are one of the things that we need to learn from each other here. I don't think the conversation will end here. For every one of us in this call, probably we need to follow up on this as well. If Ethiopia intends to introduce, a production of plant peanuts, and how should we go about it? Where should be the starting point? Who are we going to consult and contact, taking this moving forward? I don't think this is only an academic conversation that we're having now. So this malnutrition is an issue. It's an important problem for child mortality. So, having this sort of infrastructure in our country could contribute a lot in reduction of morbidity and mortality as a result of malnutrition. And thank you for bringing that example. It's very, very important. All right. Let's move. Now we shift to a country perspective. Kenya has a practical experience in applying blended finance in health. So I'm pleased to invite Mr. Stephen Kaboro. He's an economist at the National Treasury and Minister of Health in Kenya to share a case study on how blended financing has been used, the problem it addressed, the structure, and the results. Stephen, the floor is yours.
Thank you very much, Dr. Solomon. So I'll give just a brief overview of projects that we have implemented in Kenya using blended financing. I'll start with a brief overview about Kenya. So Kenya is one of the countries in sub-Saharan Africa. Basically, it's a lower middle income country with a population of around 54 million people. The GDP is around 131 billion US dollars, with a per capita GDP of around 2,400. So you realize that it is still a developing country, and I'm giving this as the presentation is coming up. So it's still a developing country, and poverty and low-income households are quite prevalent in Kenya. We have a poverty headcount rate of around 38%. When we look at the health sector, which I'll mainly focus in this presentation today, so we have around 4.7 billion USD, which is usually invested in the health sector per year. And when you look at the mix between in the total health investment, you'll find that the public sector, which is government, invests around 48%. Then we have the private sector, which controls most of the market, around 52% of the market, but they invest around 30% of the entire health spending. And we receive a lot of commitments from donors, so they contribute around 17%. And these three actually form the major funders of the healthcare system in Kenya. We do usually attract a lot of foreign direct investments. So every year we receive around 1.5 million USD in foreign direct investments, one of the top receivers in Africa. And we have a foreign direct investment stock of about 11.2 billion. So you can see investment, especially in the private sector, is quite good. Now I will move to some of the specific projects which have been implemented in Kenya. My co-presenter, Skida, has talked about the Transform Health Fund, which is funded by FSD Africa. And I'll just give specifically in Kenya what we have seen from this project. Since its inception, it managed to bring in a catalytic fund of around 5 million USD as the junior equity fund to de-risk the private sector. And this was in terms of a layered capital stack, whereby the catalytic fund would absorb most of the major risks. And with this 5 million USD funding, the joint venture was able to attract a private capital equivalent to around 111 million US dollars, with the private sector now coming in as the senior equity partners in the layered stack capital. We have seen quite a lot of impact on that project. So far, around 375 people have been able to access affordable care using this model or using this project. And around 2,800 jobs have been created. And you can see that from just that small catalytic fund of 5 million USD, a lot of funding, 110 million USD was able to be unlocked for the Kenyan market. So that is one very good example of Kenya. Now we have another three which I would highlight being implemented in Kenya. The second one being the Open Doors Africa Private Healthcare Initiative. So this is implemented through the Health Financing Coalition Guarantee Facility. It started around the COVID period, during the COVID and after the COVID. And in terms of scope, it was to provide loan guarantees for working capital from the private sector, specifically going towards capital development for the private sector, also looking at issues of funding equipment and service provision in the market. So it was this is also a blended financing structure initiative, whereby we have the private sector guarantee, which is provided by major partners like I have listed there. We have SCORE, we have Rockefeller, we have MCJ, Amelio Foundation. So they provide the capital loan guarantees. And we have Health Financing Coalition, which administers the fund in the country. And the private sector, of course, is able to come in, and with the loan guarantees, they're able to access financing from commercial banks at very good rates. So the impact so far, we have around 19.2 million US dollars that have been accessed in the loan guarantee, and they have also brought in about 30 million through the actual loans through the medical credit fund. So far, we have around 8 companies which have benefited with the loan guarantee, and it has funded around 267 facilities in Kenya. This is specifically in Kenya. The next project which you can look at is the medical credit fund, which is offered by Farm Access. And this project mainly aims to increase access to better healthcare services in Africa. And specifically, it is geared towards low-income patients who are accessing healthcare, mainly through social insurance, private insurance, and other access points in the low-income segments of the population. And the project design, it is designed to provide loans to the private sector who are specifically offering services to very risky businesses, which otherwise would not be able to access this funding within the commercial banking sector. So they will provide these loans, and the services will be provided to the population. And mainly, they reduce the risk of investment in the sector. When they offer these loans, they're able to offer them at very good rates, and they have the capacity to take a lot of heavy or risky businesses, which the private sector is not able to access, and they give these loans to them. So these loans are mainly used to finance 4 key areas. 1, facility improvement. 2, provision of equipment and services to the population, and staff and procedures that deliver enhanced care for all patients. So these terms of operations of the facilities. And the loans that can be accessed through this fund range from around 100 euros to a maximum of 3 million euros, depending on the private sector appetite for the loan. So currently in Kenya, this fund has been able to disburse about 165 million euros to over 2,100 healthcare providers who are mainly going for incubation and expansion in very risky, low-income segments of the population. And we note that this mainly works by providing loans which are mainly in risky environments, so it will de-risk the private equity funders from these high-risk areas. The last project which we look at is one that was implemented by the United Nations, and it was given through the private sector. So this project was using blended financing, and specifically focusing on performance-based reimbursements to the private sector, and whereby the private sector was supposed to offer services to adolescents and reproductive health. So basically how this works was the private sector would provide upfront capital and invest in projects that were providing health services to adolescent reproductive health areas. Once the services were provided through the private sector capital, and the private sector was able to document the social impact of this work, then the donor, who are mainly coming through the United Nations, would be able to reimburse the private sector for the capital that they have used, and they're able to reimburse this capital with interest rates, market rate interest rates, thereby unlocking private sector investments, upfront investments in health. So mainly the United Nations and the donors that they are able to pull through would absorb the performance risk if the private sector was able to document that they can give social outcome in the health. And the private sector was supposed to actually give the upfront capital and provide these services, mainly focusing on family planning and HIV care for adolescent and young women in Kenya. So the impact for that project, we had around 420,000 adolescent girls who were able to access these services. And mainly these were services whereby these adolescent girls would not be able to get through the usual traditional funding model. So with that, I would like to give a few challenges which we have seen in Kenya, specifically looking at the 4 projects. So we have several challenges which we have seen being faced by the projects. Of course, the projects tend to focus mainly on low-income households in Kenya. So there is usually a perception in the private sector that these segments of the population are high risk and therefore not bankable, or the private sector would not be willing to go into that section. And when the government provides these services, sometimes we find that the services are not optimum. So the private sector would be the best place to provide these services when they receive this kind of funding through blended financing. The second area, the second thing which we noted in Kenya as a challenge was the rates of return for private sector when they get into this market. So of course, the rates of return have to be negotiated between the philanthropists, donors, and the private equity partners coming on board. And sometimes you find that the private sector feel that the rates of return are not at par with the other areas which offer commercial rates of return. So this becomes a key challenge in attracting the private sector equity funders. The third key challenge we have noted is the complexity of structuring these deals. You will realize that the deals are very, very complex. And sometimes for emerging markets like Kenya, it becomes very, very complex to execute, to plan. You will find that most of the time we will have to bring in technical advisors to guide this, which also drives the cost up. And this somehow also delays the project implementation between conceptualization up to turning the project into commercial ventures. Another key challenge we noted was in terms of measuring the outcomes, specifically the social outcomes, especially when we see the UN-funded projects where you have to measure outcomes in the community for you to get your reimbursement as the private equity fund funders. So it becomes somehow challenging to measure this impact. You find that the digital ecosystem in Kenya is just starting to develop. So when we try to collect data, it becomes very time-consuming, very complex. And you find also the challenge in Kenya where we have very dispersed population, especially the low-income population. You find they are very dispersed, so it becomes very difficult to actually track the impact of these projects in the households themselves. Of course, we had a previous panel member talking about currency volatilities in most sub-Saharan African countries. So most of the currencies are very prone to shocks. They will be very volatile over a very short periods of time. Now, with this kind of volatility, it becomes very difficult to structure blended financing stocks because it becomes very risky over time if the currencies are not stable enough. However, sometimes we have seen some of the projects being able to hedge the currency exchange so that at least it offers some form of evening out over long periods of time when these projects are implemented. Another key challenge, which also comes a lot in Kenya, is economic shocks. So the market is usually very sensitive because of the income levels of the population. So sometimes an equity fund would come in and they would say that over time a small shock in the economy actually affects a lot in terms of how the project is executed over time. So for example, currently in Kenya, I think we have just started to feel that there could be a drought coming in the next few weeks. I think 3 or 4 weeks. We could be facing a drought in some of the areas which have very low income households. So when we experience such kind of very immediate, very hard shocks on the households, they reverberate very much into the economy, and you find that these households, the way you had planned to implement the project, is seriously affected by these shocks. So this affects how the projects are structured and how the projects move forward. And sometimes it becomes also very difficult to de-risk some of these projects. So with that, I think I would hand over back to Dr. Solomon as moderator. These mainly some of the key projects that we have in Kenya, and open for discussion. So back to you, moderator, and thank you very much.
Thank you so much, Stephen. I think you guys seem to be doing a lot of work. It's very encouraging. There is a lot to take. I'm also happy that you walk us through all the challenges, because if any one of us here are interested to introduce blended learning, especially engaging the private sector, now we know what the challenges are, but we would have also a mitigation plan to address those challenges. I think we all know that blended financing, when it comes to health, is underrepresented. It's only 6%, unlike other sectors. So, but here, from your presentation, we came to know that there are lots of projects going on. There is a huge involvement of private sector with de-risking model given up from different partners and investors. You highlighted the importance of loan guarantee, access to loan, and how that fund helps develop infrastructure and staff development, which are very critical inputs when it comes to women, children, and adolescent health. So there was so much to learn, and I hope the audience must have taken a lot from your talk. Now, we widen the lens to a development finance perspective. It's my pleasure to welcome Ms. Venat Kaltur Ondesi, Global Head of Health at the International Finance Corporation. She will share how development finance institutions look at blended financing, what attracts private investors, which is very, very critical. That's, private sectors might not be interested to invest in health. Health is not appealing when it comes to making return on investment. And we're the strongest entry point in women, children, adolescent health. This is also very, very critical. Over to you, Zeno.
Thank you so much, Dr. Solomon, and thank you for inviting me to this great conversation. I've been learning a lot, and I'm so glad I didn't plan to share about MEDAC's Medical Credit Fund or Transform Health Fund. It was great to hear about those great examples. Let me check if you can see my screen. And I apologize, a lot of the things that I will talk about is going to repeat what my fellow speakers have been saying. So I'm going to try and avoid that. But I think maybe I will start with what we think, what IFC has developed over a number of years ago as principles for blended finance, which is now adopted by a number of development finance institutions. And you'll see there is a very important commonality among all of these principles is to leverage grant funding to mobilize more funding as opposed to competing or fragmenting the market. So very quickly to go over the principles, we would need to have a rationale for using blended finance. What is not available in the market? What gap are we trying to close in the market? That rationale needs to be very clear. That's the first and foremost principle. Again, as I mentioned, the idea of blended finance is to crowd in as much commercial capital as possible with limited concessional and grant resources. So the minimum concessionality that's needed to do that is the second principle that we adopted when implementing blended finance. Third one is commercial sustainability. Our approach to blended finance is a bridge to enable private investments to achieve commercial sustainability in the future. And the reason for that is to make these private projects not dependent on permanent grant funding, which we know is very high risk for many of these projects. So that visibility of eventual commercial sustainability is the third principle. The fourth principle is, again, blended finance addressing a market failure. And again, rather than distorting the market and crowding out private sector. It's something that, again, we put a lot of emphasis on. And the fifth principle is that through our blended finance transactions, similar to our mainstream transactions, we enforce very high standards of corporate governance, E&S principles, ethical and quality principles. So these are the 5 principles that we apply, and a lot of the DFIs apply when we implement blended finance. And in fact, we would need to tangibly show how we fit all of these 5 principles whenever we take any blended finance transaction to our committees. So as you mentioned, health is underrepresented. I thought it was 5%, but Dr. Solomon, you corrected me, it's 6%. It is underrepresented in the overall blended finance landscape. I think one of the things that we need to be cognizant of is that the projects in healthcare are also small in size. So that underrepresentation may not be that strong as we think, in fact. But one of the challenges is that we usually have, and Skander referred to this as well, we usually deal with smaller projects that are more difficult to attract certain investor types. Now, the funding gaps in health are growing, and this is both because of fiscal spaces competing with many other sectors and getting narrower and narrower, and also the traditional grant funding sources, declining. In fact, only last year there has been a 20% decline in global health ODA financing. Now, we've been talking about eventual commercial viability, financial sustainability, which we think is crucial for private projects in health to be sustainable and long-lasting. But these are also foreign concepts. Only maybe until a few years ago, you couldn't even mention the importance of commercial viability in the health sector, given the importance of health as a public good. The other challenge I'll talk about is the fragmented donor landscape. Again, one of the issues we face is that we're dealing with very small projects, even in aggregation, and there are funding available for specific products or specific areas like women and health, very important issue. But with that kind of very small large number of donors looking at different pieces of the puzzle, sometimes it's hard to attract larger private capital into this space. Again, everybody talked about the high perceived risk. I will emphasize that the risk is not just commercial, financial, but there's also a very high reputational risk, given that we're dealing with patients in healthcare, which is also reducing appetite of investors. And in some cases, the success measures are not easy to measure, because it's not only number of people you reach, it's also the health outcomes, especially in the preventative space, very hard to measure the success factors. But there are also very large opportunities that we're seeing right now to see, and that we think is going to fuel more blended finance coming into this space. First of all, health being recognized as a major investment for both public and private stakeholders now, not just an expense, that actually has very strong returns in terms of human capital and economic development, as well as job creation. There's more and more private sector involvement in healthcare that's bringing in innovation, agility, and scalability. An increased public-private collaboration, again, is growing the market, both on the provider side, but also on the financing side. There are many opportunities across the value chain of innovation to manufacturing to delivery to supply chains that the private sector is investing in. And also, given the decline in grant financing, there's a bit of an opportunity there as well. The strategies are now changing from and I'd be very happy to be corrected by many experts on this event. The strategies are changing from purely deploying grant funding to leveraging grant funding for mobilization of additional capital. And we're seeing more and more players, new philanthropies coming into this space. And where we see key areas of catalytic capital scaling is health SME financing, increasing access to rural areas, enhancing primary care, preventative care, supply financing, and local manufacturing and supply chain development. Again, I wanted to share a few case studies of blended finance transactions that we have applied. And I wanted to start with this one because many of the speakers also talked about the local currency challenges. And in fact, I should have talked about that also when I refer to the challenges in the space. Many of the facilities available out there are not able to solve for the high cost of local currency financing for health or private companies. And it's very difficult to de-risk local currency risks with traditional blended finance structures of like first loss or parallel structures. So one of the facilities that we have, a local currency facility under the private sector window of IDA, has its own swap arrangements that is able to bring in concessional swap costs to the projects. This is actually the highest level of concessionality that we're able to offer, and it's very hard to get approvals for this kind of a facility, but it's able to reduce the swap costs and bring more conducive local currency financing to the market. And in doing so, it crowds in the private sector who's offering its traditional loan spreads, the private financing, but while subsidizing the funding costs. Another case study I wanted to refer to, again, we talked about the small size and difficulties in attracting capital project by project to especially the health SMEs. And here is a structure where we work with banks. We have done this in Africa through the Africa Medical Equipment Facility, where we brought in equipment providers, donors, IFC, to provide very low-cost guarantees to banks that can then on lend to SMEs in their markets. And because of the lowered cost of guarantees that IFC as a AAA institution was able to provide to these banks, the bank's appetite for health SMEs and the type of financing they could provide to the health SMEs was able to be enhanced. Again, if I may move to another structure, again, we're looking for structures where pure commercial financing is not able to measure and take all of the risks available, but pure grant funding is not available to fund the full projects. And one of the examples for this is, for example, vaccine manufacturing in Africa. And here you have very low track records, long gestation periods for commercialization of products, uncertainty on the offtake side. You'll see this, HPV vaccines, for example, for our specific topic, very important vaccines that can be locally produced for secure access, but requires a lot of capital upfront. That's hard for commercial institutions to finance. And the way we address this kind of a project is bringing in a substantial amount of first loss capital to catalyze commercial capital. So we have done this in a transaction in Senegal where we were able to catalyze 50 million funding through about 40% first loss, which is a very high first loss. We usually see 20 to 30% first loss to use minimum concessionality, again, adhering to our principles. But in this case, the risk was so high that we had to start with such a high first loss. But over time, again, going back to our principles, as the commercial viability of these projects are proven, you would reduce the concessionality and attract more capital to these facilities. And the last that I wanted to talk about again is, again, I will talk about how aggregated platforms can address specific sections in health that require different types of capital. And here is a facility that we're looking to launch, actually, again in Africa, to support local manufacturing. And this facility would bring in not only blended finance through various staggering of different tranches of capital, but also technical assistance. And again, many of the other speakers also referred to this. Many of these companies need a lot more than financing. So when we talk about de-risking, which is one of the main objectives of blended finance, bringing in tied technical assistance is part of that de-risking to basically enable some of the companies to accelerate what they need to achieve to sustain their businesses. So bringing together all these different aspects as a one-stop facility, we believe is going to address some of the issues like Skander was mentioning, again, in terms of the smaller size of the companies. And one of the innovative methods that we're trying to also implement here is to tie to procurement programs and volume and payment guarantees to also de-risk the demand side of things. So this is not easy to do. It requires a lot of partners to come together, but it's also one of the objectives of coming up with an aggregation like this is to address that fragmentation issue in the market, where many of the companies are now being approached by multiple institutions that have complementary offerings, but are unable to bring these together as a package to get a visibility of funding and technical assistance required until they reach self-sustainability. And this facility is basically meant to achieve that kind of a one-stop shop approach. So let me stop there. I try to avoid repetition, but I think there are a lot of common themes there. But I hope that was useful. And back to you, Dr. Solomon.
Thank you so much, Zainab. That was really useful. You don't have to doubt. That was brilliant. Thank you so much. You highlighted very, very important things. Now we know the development finance institutions principles are. So this is key. We also see there are lots of opportunities. Instead of the challenge that I was looking at, the opportunities, it's an immense. So this is something that's very reassuring that blended financing can work, whoever intends to do it. And it's also important that we see that you cover all important areas when it comes to women, children, and adolescent years. There is the blended financing can work through primary health care. You've mentioned the supply chain, which are all critical pieces when it comes to women, children, adolescent health. And then the vaccine case study is also critical because when we talk about children health, most of the children in sub-Saharan African countries are affected by vaccine preventable disease. So having a vaccine production facility means a lot for Africa. So we seem to learn a lot. And last, and which is very, very important piece that you've mentioned about it, the technical assistance. You could avail the funds, but funds will not do everything. And having the expertise, on the ground, making this happen is also critical. Thank you again, Dennis. Now that will take us to the last part of our session, which is the Q&A. We'll be taking questions. Please continue submitting your question through the Q&A box. I'll direct each questions to the relevant speaker. All right, so far, in the meantime, Joanne, you can step in if you have anything to say. But in the meantime, let me check if I have questions forwarded to speakers here. All right. One of the participants asked this. I'm particularly keen to learn about the available research and case studies illustrating how blended financing has been used to expand essential primary health care and community-based services to underserved groups in different settings. I think both Joanne and then can respond to this question. Do you want me to repeat? Did you get that?
Sorry, if you don't mind repeating, my
Yeah,
audio
I
went
will
out.
repeat.
Yeah.
One of the participants is keen to learn about the available research and case studies illustrating how blended financing has been used to expand primary health care and community-based services to underserved groups in different settings. So it's about if there are any evidences, whether or case studies that you show whether blended financing has been applied to expand primary health care, which is the
Yeah. Yeah, thank you so much. So I'll start. I'm sure our other speakers have much more expertise in this area. Currently, in the transaction that we're doing in Indonesia, where we launched a $50 million facility that provides both technical assistance, concessional financing, and equity financing, and also guarantees. The direct impact for health is that this facility is being structured alongside a $4 billion loan. So the facility is meant to look at the gaps, and some of the gaps that we've identified, as was mentioned by the IFC speaker, was in manufacturing of vaccines. And so that upfront cost for vaccine development is really needed. And so what the facility will do is it will provide that original 5 million of TA that is needed to really get everyone in that partnership and deal structure to be able to scale, and also the money for things that finance ministers don't fund, like advocacy and awareness, because you could have a diagnostic, you could have a vaccine, but if you don't have a patient that's actually aware and can consume the product, I mean, we think about it as health, but it is a product at the end of the day, then there'll be a market failure. And so what we are looking at in that health impact right now is really to meet the demands of that $4 billion fund along the healthcare continuum. I'll turn it over to the other speakers.
All right. Zainab?
Yeah, just to add to that, I fully agree with Joanne. But again, some of the facilities that I talked about to address the health SMEs, they're specifically geared towards primary care and rural areas, because these are the areas where it's hardest to attract commercial capital, especially bank financing, because they're low capex, security not available, very small sizes. So the Africa Medical Equipment Facility was specifically designed to enable these primary care facilities to acquire equipment. Similarly, the speaker from Kenya spoke about medical credit fund, also has a lot of access for primary care. I think one of the challenges that we see there is that, working through banks, that the viability of the primary care model needs to be strengthened, because again, if you are making these facilities grant dependent, like many of the social franchises are that play a very large role in Africa, for example, for delivery of primary care, once that grant funding is not available, the clinics close. That's why creating viable models, business models, are as important as bringing in the right type of financing. And I think the tech enablement and other private sector-led innovation is making that happen. So some of the health tech supported primary care models, I think it would be great to study to see how they can make primary care a commercially viable business model as well, to attract more private capital here, in addition to bringing in the blended finance.
Wonderful. Thank you so much, Dina. Carter, would you like to say anything?
Thank you, Dr. Solomon. So I wanted to add a couple of things. First, I second what Zainab just said, is sustainable models is key. Building sustainable models. Actually, we've seen a fantastic nurse-led woman nurse-led network of clinics in South Africa, but that model relies on grants. The day those grants stop, these clinics will probably shut down. And together with the Health Finance Coalition, we tried to put some TA to help address that vulnerability, meaning that how do we make those models sustainable in the future? That's one example. The other point I wanted to mention, Dr. Solomon, is speed. We had actually a situation last summer where a very critical factory that provides medical oxygen to one Eastern African country was in the middle of being built when actually one funder had a challenge and couldn't disburse the loan to complete the construction. And so we stepped in as a Transform Health Fund and actually put in place a bridge financing to allow that construction to continue and to complete that plant. And so this is the role that players such as ourselves can play also, is that filling a gap, even if it's a temporary one. And so speed is critical in this case, in being able to react to crisis situations the way we did last summer in financing this oxygen generation plant, medical oxygen. Thank you.
Thank you so much, Guy. All right. So far, I have only two questions. Second question is, I think it must be from the same person. It reads, blended financing in resource mobilization or transaction is somehow clear, but I would love how it works I would love to hear how it works in provider payment modality, blended provider payment. Since many of the countries are obtaining financial resources from multiple sources, can we say that it's blended? Repeat. Let me get this clear, right? So this person is interested how blended financing in resource mobilization or transaction is working. How does it work in provider payment modality? Since many of the countries are obtaining financial resources from multiple sources, can we say that it is blended? Can we say that it's blended, Joanne?
Put me in the hot seat first.
Yeah, because it was you who were trying to demystify the blended financing.
I know, I got to demystify it. That's why I brought our colleagues from African.
It's all right.
I think, a country receiving financing from multiple sources is what we've seen to date in many of these blended financing transactions. I mean, I remember when, I was sitting on the initial board of the Global Financing Facility at the World Bank, and Sweden was bringing in their capital, Norway, USG, and others. And one of the things that GFF eventually became was a World Bank facility, but it was supposed to become its own blended financing facility. It was supposed to be totally independent. And so I would say that this has been an argument, and that was almost like 11 years ago. This has been an ongoing debate for over a decade. And a country receiving sources, is not necessarily an example of blended financing, right? Because it's grant capital, right? And GFF, it's debt. I think the true blended financing, as the speakers just mentioned, is we need all of these different instruments, right? We need a guarantee. We need the grant to provide that concessionality for the investor that is risk adverse. But I think the other thing that we need is also the financial diplomacy of integrating these different types of capital in the ecosystem. So in some of the countries currently in Southeast Asia, we have several development banks that are giving billion-dollar loans, foundations. It's all blended. It's all meant to be catalytic capital to attract larger private sector capital. So I think the issue is not whether it's blended or not blended. I think the issue is how do we coordinate a lot of that capital coming into these countries in a way that we could take the 1 million and make it 100 million, the way Transform Health Fund did, and really coordinate as the different types of capital are coming. Right now, in some countries and in Southeast Asia, we have 4 billion loans. We have 2 billion of concessionality. I mean, it's not lack of money, I always say, which is controversial. It's how we structure the money. And so different types is not blended. It's not wrong. What we need to do is coordinate that type of financing so that we can create the proper vehicles. And I think forums like these will help us exchange information and really deploy capital so it's efficient and effective.
Thank you so much, Joanne. I think we're left with 3 minutes. Maybe final words, any take home that you would like to forward, Zainab, Skadar, and Joanne, and then we'll
Dr.
open the floor.
Solomon, if you don't mind, I wanted to take
Please,
half a minute to add to Joanne's response because I
please go
think we're
ahead.
all thinking about blended finance on the provider supply side. If I understood the question correctly, I think there are a lot of opportunities to create blended finance structures on the demand side, especially now that governments are struggling to increase their domestic financing capabilities. So one of the things that the World Bank Group does, both on the bank side and through MIGA, is to de-risk commercial banks lending to governments. And with the reduction of the financing cost for the governments, the amount of financing savings are directed to less commercial investments. So this is a structure called debt swap that again enables the governments to access cheaper funding and earmark the savings towards less commercial investments, which in some cases could be in the healthcare space. So again, I think it's a great question because we need to think beyond just supplier side blended finance. And thank you again for inviting me to this event.
Thank you so much. Thank you, Zara. And if you guys don't have any final word, all the speakers, I just want to thank you all for this wonderful talk and the responses that you provided. Thank you so much. Now we can go ahead do the Mentimeter evaluation poll. Take a short reflection poll. Please take a moment to answer the final questions on the Mentimeter. I hope you guys have been already familiar with Mentimeter, because your feedback is very helpful to identify next steps and the kind of support countries may need. So you'll have 5 to 7 minutes to complete. You go ahead. 5. Hope we're done. Yes, thank you so much. Thank you all for completing the poll. Let me briefly summarize the key message. So I'm not going to take much of your time. So, few of the key points that have been highlighted and the takeaways are: number one, blended financing is a practical way to mobilize additional resource. It's not the only solution for alternative financing mechanism, but it can be considered as one way to mobilize additional resource to enhance women, children, and adolescent health. That's number one. Number two, it works when catalytic capital help to de-risk. I think de-risk here is the key word, because most private investment I might not be interested because it has a high risk business. So if we do a de-risking, we can attract lots of private investors into this. And number three, partnership between government, investors, development finance institutions, and philanthropy is key. Number five, grants are not sustainable, but blended financing may be sustainable. It's also very important to fill in some gaps, like it's been mentioned earlier. And overall, it seems that there is a strong interest in exploring continental blended financing vehicle and in continuing the conversation to a planned session in the future. So I think JLN will probably may sort this out on how to guide, network, any country or would be interested to introduce blended financing into their health system to enhance women, children, adolescent health, because it requires lots of consultation, I think, and we need to know who turn to for guidance, for consultation. People might also be wanted to, if they have an idea and if anybody is interested in this, where do they start from? Where is the starting point? So I don't think the conversation is going to end here. It would continue. This is not an academic conversation. This is something practical. We all, in sub-Saharan countries, would be interested to improve women, children, adolescent health. So thank you all for the rich insights shared today. As I close, I would like to thank all the speakers. Thank you, Joanne. Thank you, Stephen, whoever is here. So Skardar, and if anybody I miss, I'm so sorry. The JLN Secretariat, the National School of Government South Africa, our technical and coordination team behind the scene who's been active, and all of you who joining and contributing to the session today. Before I close, I'd like to mention that the next JLN webinar is going to happen on February the 5th. Save the date tile is now on your screen. I think you could share on participants' screen with a QR code for your registration. Thank you once again, and we look forward to seeing you at the next session. And goodbye from me. If there is any housekeeping issue, anybody can step in. And over to you.
Thanks, Doctor. Thank you.
Thank you so much.
Thank you.
Bye.